All right, Dr. Mike, good morning or good afternoon, depending on which way you look at it. So
Good afternoon for me.
we've got a pretty decent time difference going on across this internet connection, but we're making it work.
I would absolutely say so. What is it? I mean, what time is it now for you locally?
We're just after 6 a.m. here in Sydney. It's a cold morning.
4 p.m. over here. So what's that? I don't even want to go into that. That's what, 14 hours?
It's too early for me to do the numbers.
Too early for you to do the numbers. Too late for me to do the numbers.
There you go.
Two different sides of the same fucking excuse.
So last week we talked about rehab and how that fits into our continuum of patient care and how we use that. I think that was pretty cool. That sort of got me thinking about how I've used that in the past, and did that process play out the right way, and was that the right thing to do? So that was a good one. Hopefully that was relevant for people. Today we're going to switch it up a bit again. I think we've got some more value to add.
Yeah. We're going to talk about things that we see as providers that are, one of the things that we love to do is diagnose correctly. So with diagnosing correctly, that assumes that other people are diagnosing incorrectly. So there's a handful of things that we see on a visit by visit basis that are very, very commonly misdiagnosed. So we just wanted to roll through those misdiagnoses in the hopes that, hey, maybe somebody out there listening is like, you know what, I thought I had that. They were trying to fix that, when in reality, it's something completely different and very fixable long term.
So we're talking about maybe like a top 3 kind of list of things that we see coming in that have been explained as X, but our understanding is maybe Y.
Well, it's not even our understanding. It's the truth is why.
There you go. Boom.
Like it's not our understanding. It's like people think it's one thing, and factually it's a very different thing. So this isn't up to any interpretation. This isn't us looking at a particular condition through the lens of the way that we practice. This is a tissue specific diagnosis that once obtained and once skillfully treated, that you fix it very, very well.
Yeah, sometimes the initial way that it's explained is more to do with symptomatology. So it's going to come in more to do with what's just causing that problem right there, or what's actually causing that pain at that point in time, versus what's actually going on and what's actually driven that process to happen. So they're two very different things. Needs to be explained in a different way, and needs to be treated in a very different way. So with that said, let's start with the low back today. Is such a big problem, low back pain for a lot of people around the world. Pretty common presentation when you speak to someone that has had acute low back pain. One of the big symptoms that they get is they get some kind of muscle spasm. You get some kind of splinting in the low back area. You get a big lot of tightness because that area doesn't want you to move. And it's not uncommon sometimes for people just to get told you've got a muscle spasm. Let's put a heat pack on it. Let's, do some massage. Let's do whatever we need to do to get those muscles released, and you're going to be good to go. Which, our understanding of that is that that's just throwing stuff at the symptoms, and there's a reason for that muscle spasm. There's a reason that splinting is there. There's a reason that movement has slowed down, and the body is trying to stop that from happening. So, what is the number one cause, Dr. Mike, that we would often see underlying to a general muscle spasm in the lower back?
Yeah, so a general muscle spasm in the lower back is a result of one thing, and that's a lumbar disc irritation. And that lumbar disc being irritated is bad news bears for the body. So that muscle spasm is actually a protective mechanism to ensure that you don't further damage your disc. So it's one of those things where you want to let that cool down a little bit. You want to let that disc start to heal, and then you want to go in and attack the reason why that lumbar disc was irritated. So oftentimes a patient presents to my office and they'll say, hey, my quadratus lumborum or my QL is jacked up. They'll say, hey, I bent over and I threw my back out. I blew my back. I pinched a nerve, whatever it may be. A lot of times you come in and the really chronic patients that get this happening in a recurring manner will say, hey, my hips are out of line. My doc has to go in. He has to even out my hips with a nice chiropractic adjustment. So that disc is becoming irritated because there is adhesion in the lumbar spine, and that adhesion is causing a greater degree of compression on those discs, and it's just increasing the likelihood that you're going to irritate it. If you took out a model or you took out a spine, and I'm anticipating that nobody here who is listening to this has a model of a spine or anything in their house, I guess, right? That disc should be able to kind of teeter-totter, if that makes sense. When there's no adhesion in there, it's going to teeter-totter when you bend forward and backwards. So say we have adhesion on the back side of that disc and it can't teeter-totter, right? So it's just kind of levering. And as you lever and compress that thing down, that disc is going to irritate out that way. So the true diagnosis of something like that is going to be a disc irritation secondary to basically posterior adhesion in the lower back. And you go in there, you let that disc heal, you calm everything down, you allow that spasm to take care of itself naturally. You don't blast it with proprioceptive feedback. You don't adjust it. You don't heat it. You don't do McKinsey extensions. You don't do anything. Allow it to cool down to the point where you can test those tissues relatively symptom-free, and you go and you fix that adhesion, and people magically don't get lower back spasms anymore.
Yeah, it's okay just to let that rest.
Right.
I've been in that boat, and you tend to want to do something. You don't feel right. You can't move well, so you want to take action. But in that case, it's okay just to let it rest, just to let it cool off. And you do then need to come back to that when you've got the movement back, because you may feel good and you may be moving pretty well. But that problem that Mike described is still there. So that's the opportunity then to where we get to assess that. We can look at that range of motion. We can figure out where in that spine is it not moving well, and what do we need to do to take that block away.
Yeah, and if you're calling, here's a practical tidbit. If you're calling a chiropractic office and they want to see you in that state of acute pain, typically what's going through their brain is like, oh shit, I need to see this patient. I need to fill my time. I need to fill my patient numbers. So yeah, of course they're going to see you. If you call the right doctor up and you tell him about your pain, and he can easily explain to you what to do in 5 minutes to just relax, and then get you on the schedule in 10 to 14 days when that thing calms down. And then when that thing calms down, that's where your big area of opportunity is. So if you're calling up an office and they're like, yeah, we'll see you right away. Oh, sure. We absolutely need to do this. Yeah, we can help you fix it right now. They're full of shit and desperate for patient numbers.
Yeah, you want to relax in that moment, really. The urge to take action is there, but sometimes that can be quite detrimental. Going and getting a massage, for instance, there's some horror stories out there that I've heard from people where they've been on a table with an irritated disc, a lot of splinting going on, a lot of muscle spasm. You spend an hour on that table, and if the therapist does a good job in terms of what they're there to do, and they're releasing a lot of muscles there, when that person goes to move again to get off the table, sometimes they're in a world of pain, and they're not moving for quite some time. So trying to force this thing sometimes just brings about much more of a problem.
Yeah, you can make the disc much worse, and there's a point of no return with discs, right? I mean, you can get some sort of improvement on some sort of disc, but once that thing protrudes, once that thing herniates to a certain degree, like, it's not going back in. So you can actually make it to where you irritate your back, if you just wait, right? If you freaking drink a glass of wine, have a CBD gummy, whatever the hell your relaxation drug of choice is, and you wait 10 to 14 days, then you actually get it fixed and figured out, you can avoid a situation where you go and you get that thing blasted with proprioceptive feedback, whatever. You get the symptoms to go down, you lure your body into a state of false sense of security, and then you go and you fuck it up even more. You make that disc even more healthy, and now you've got to go in and get surgery. I've seen it happen before. I've seen it happen in previous practices that I worked at where, yeah, somebody comes in and we put you on decompression, we give you McKinsey extensions, we put heat and stim and ice and all this other shit on you, and then you come back in next week and you've got unrelenting radicular pain down your leg, and we fuck that up. So yeah, you can fuck it up to the point of irreducible dysfunction where you need to be cut open, and it's just a ticking time bomb from that point.
So yeah, if your low back is locked up, then maybe put down the lacrosse ball, put down the spiky ball, put down the heat pack, whatever else you can think of. Yeah. Get in touch with an ID provider, let it cool down, and get it assessed a week later.
Yeah, the right person will tell you to just chill for 10 days, and they'll say, okay, we'll get you on the schedule. You hurt yourself on Friday. 2 weeks from now on a Friday, I want you to come in. That's it.
There you go. All right. So we're moving on. What's the next one that you see most commonly?
Oh gosh. I mean, that's a tough question. It's like picking your favorite flavor of ice cream, right?
All right. Well, let's stick with the low back hip, right?
Sure.
So if we come around to the front of the hip, pretty common for people to point to that front part of the hip and go, dude, my hip flexor hurts. I've got a hip flexor problem. What do we know about that?
Yeah. I mean, somebody comes in and they say, hey, I've got low back pain or I've got hip pain. It's, at the bottom of a squat. When I'm sitting down for too long, my hip flexor's tight. My hip flexor's tight. My hip flexor's tight. First of all, no tight muscle is an adequate diagnosis. Second of all, it's very, very, very rarely your hip flexor that causes any sort of pain when your hip is in flexion. So that is technically a hip impingement that you're feeling in the front. And that is then secondary to dysfunction in one of two or both tissues of the adductor magnus and the posterior inferior hip capsule. So I guess we can kind of continue the visual aids, right? When your hip goes to flex, right? You've got a hip like this. Try to move this out of the way a little bit. When your hip goes to flex, it should flex and slide posteriorly into your hip joint. If you've got shit down here, if you've got gunk and it can't slide posteriorly, what is it going to do is it's actually going to impinge onto that top part of your acetabulum. Same thing happens to a different degree with the adductor magnus. That's going to limit that hip flexion. You go ahead and you fix those two tissues, and all of a sudden that femoral acetabulum relationship improves, basically your hip bone with your hip joint, and you don't get any symptoms in the front of your hip. So, you could stretch that hip flexor to your heart's content. You can keep grinding through it. You can have somebody do, even we can try to treat your hip flexor. That's not going to happen, right? We have a treatment protocol for the iliopsoas tissue, but if you don't get that diagnosis right and you go to treat that muscle, then it's just not going to make any improvement.
Yeah, the whole thing in itself is a bit misleading, I think, because, you get this pain when you're going into hip flexion, which means you're not actually lengthening out the flexor anyway. So you'd need to go into a full extension to really put tension on that stuff anyway. So yeah, I think it's just the words get crossed up. So it's just sort of anything in this general area, it must be a hip flexor. So it's a little bit misleading. And I mean, you can sort of understand why, right? Because who would think to go to the adductor magnus, which is, almost part of your hamstring and down in the middle part of the thigh, to treat pain that's happening up there. And also the posterior hip capsule. I mean, that's, it's hard to get to unless you really know what you're doing. So it's not a common thing to think of. And, it's more common for people to get out their favorite roller or their lacrosse ball or their spiky ball or whatever it is and just blast away at the front of the hip, which really all that's going to do is just piss off whatever tendons they're hitting at the front there. Or maybe try to get into the psoas, like get something really deep in there. The psoas.
Yeah, fucking piece of plastic that
and just crush your guts.
Crush your guts.
But
yeah, I mean, don't get me wrong. If you're in the bottom of a lunge and your back foot is experiencing some symptoms in the front of your hip, I'm going to be suspicious that a hip flexor is causing that. But in the bottom of a squat, or when that front hip, or when any part of your hip is in hip flexion and you're experiencing anterior hip pain, it just can't be the psoas. It just can't. It doesn't make any biomechanical sense. And you said something that kind of made me laugh. I just spit into the freaking camera. Who would think to treat the posterior inferior hip capsule, or who would think to treat in the adductor magnus? Well, people who have an understanding of what's going on, right? People who have an understanding that's more than just like elementary human biology, right? They understand that the hip capsule is the first thing that would limit hip flexion, because a capsular adhesion is going to influence the joint in the most comprehensive way. And you also understand that the adductor magnus is going to cross that hip in such a way that it can limit hip flexion. So who's thinking of doing that? People who've done their homework, people who are good doctors, right? It's not something that you learn right out of school. It's not something that you have this inherent understanding of after you take apart a body in cadaver lab. But it's ridiculous for us as practitioners to think it's like something special for you to understand that those two structures are the structures that you need to treat in that instance. Like, it should be common knowledge. It should be as common knowledge as, I have strep throat, here's penicillin or amoxicillin or whatever it is. Or I have diabetes type 2, here's a temporary dose of metformin while we manage your activity level and your diet. It should be that common knowledge. But the fact that it's not is the most infuriating thing ever. I mean, the fact that it's not allows us to charge a premium for a product that we've worked very, very hard to develop. But you should be able to walk into any physical therapist office in the country, any chiropractic office in the country, and for them to look at that and say, yeah, the hip flexor doesn't even lengthen in hip flexion, it's contracting. So why would we need to lengthen that in our treatment? And here are the structures that will limit hip flexion.
We'd be remiss not to mention as well that that's a common presentation for, and this is a soft tissue structure that's blocking this hip flexion, but then we could have some bony change as well. So depending on who it is, and maybe the stage of life, there could be some degeneration in the hip. So we could have some bony change that's causing the pain there at the front, which is not necessarily something that we can affect directly. We could have, the FAI, there could be some other congenital bony change there. So there are some other things here that aren't just going to be related to adductor magnus and posterior hip capsule. But it's just less common.
Yeah. And any good provider will be able to tell you that stuff with about, like, if somebody comes in, I'm almost 90% certain if they have an FAI or a CAM deformity, or if there's arthritis or even a labral tear. Like, you can know that not to 100% certainty, because you don't have MRI goggles on, but I can move your hip into flexion, play around with the angle at which we rotate it, and determine, yeah, you've got an FAI or a CAM pincer deformity. You don't. You've got a torn labrum. You've got degeneration. That's another mark of a good doctor, right? Is finding that diagnosis and saying, hey, this is 70% adhesion, 30% pathological changes to your joints. So it's like understanding that, and understanding that once that adhesion's reduced, and maybe your hip's only at 90%, but that's when your treatment plan ends and saves you from coming in for 6 more visits. That in itself is worth its weight in gold. So not only treating the right structures, but knowing when I guess you've maxed out your potential for range of motion.
So if you've got long-term hip pain at the front of the hip, when you pull your knee up, when you squat, when you get down on the ground, there you go. Something to think about.
Yeah. See somebody that can actually fix it and knows what's going on. So, and we know what's going on.
So low back, hip. Where are we going next?
Let's do a neck. I get a lot of people with like long-term neck dysfunction in between the shoulder blade pain, right? That's a really, really common diagnosis or a common chief complaint that people present with. And they're like, yeah, I've got pain in between my shoulder blades. And then when I go in and diagnose them and I say nothing about anything that's happening in between their shoulder blades, they're always like, but my pain is down here. You didn't touch my pain over there. And it's like, yeah, because your parascapular pain, your bilateral parascapular pain isn't caused by anything that's in between your scapula. 9 times out of 10. What's it caused by?
Well, it's dysfunction in the neck, isn't it?
In the neck. Yep.
So we run that person through a functional screen to see how much movement they've got at the various levels of the cervical spine. What's the number one? Is there a number one thing that you see most of the time that most people are deficient in?
In terms of the neck?
Yeah.
Yeah. I mean, it's typically suboccipital pain, suboccipital dysfunction that is causing then that pain to refer to in between the shoulder blades. You get that kind of initially. So that's where it's like kind of happens high in between your shoulder blades, if that makes sense.
So we're talking about being able to flex the neck at the very top segments of it. So a lot of people will often be pointing to the back, like the bottom part of the skull, and going, yeah, it's really tight and sore here. And that's going to be blocking the ability to move there. So when we put you in that position and we put the goggles on and we do that, it's usually very hard to get there. And that's typically where most people are jammed up.
Yeah, and that'll refer to in between the shoulder blades. It's not going to be deep in between the shoulder blades, but you're talking kind of at the top of where the shoulder blades are. A lot of times people will be like, oh, it's my levator scapula, or hey, it's my trapezius muscle. And when that dysfunction then starts to push its way down further into your neck, that's when you start to get the people that are like, oh, my rhomboids are tight. My rhomboids are tight. So it starts as a dysfunction in the suboccipitals, those muscles that basically connect the base of your skull to the top of your neck. And then as those start to deteriorate and it pushes load further down your neck, you'll get basically like C5, C6, C6, C7, T1 degeneration happen. And that's really where it starts to get really, really sharp in that rhomboid area. You look at why suboccipital muscles get to be that level of dysfunctional, and it's a postural thing. So those muscles are supposed to just control the intricate movements of your head, right? You're a bipedal animal, right? So you're upright all the time. So you've got to have really, really, really great motor control of the way that your head rotates, right? Bam, bam, bam. Because if there's a fucking saber-toothed tiger there, I want to just be able to slowly look, right? I don't want to have to move my whole fucking body like an idiot, because then I'm dead. But what happens is we spend a lot of time seated, as we spend a lot of time like this, as we spend a lot of time like this, down like that, those muscles have to become postural. And so anytime a tissue is overloaded, anytime a tissue has to do twice as much as what it's intended to do, what it's evolutionarily designed to do, you're going to overload it. So it's, sometimes people come in and they're at 20% function of the suboccipital muscles. They're at 30% function of the suboccipital muscles. And you clean those bad boys up and all of a sudden they're like, yeah, my trap pain, it's gone.
Yeah, and these muscles are super important because they're loaded with receptors for sensing movement and proprioception. So this small complex of muscles up at the base of the skull, they do a hell of a lot in that connection between where your body and your head is in space. So when it can't do that properly, when it's loaded up and it's not moving well, there's a big disconnect. So people are often getting a lot of headaches. They're often getting a lot of, can be dizziness. There's a whole spectrum of problems with varying levels of degrees of how bad it is. But cleaning that up and getting that moving well. And, for people to just be able to tuck the chin in and do that easily without getting symptoms everywhere, and for a nice smooth movement, you can really see who's restricted and who's doing that easily. And it's a huge difference.
Yeah, and if you can't give yourself a double chin without any discomfort, then chances are you have some dysfunction up there. Yeah, you brought up a good point too with the headaches. Those muscles will actually attach to, I mean, I don't know how in depth we want to get to, but those muscles will actually attach to nervous tissue. So like the sheath that your spinal cord and basically the sheath that surrounds your brain is attached to. So if you get tension and tightness there, it's actually going to pull on that dura, that little sheath. And yeah, you get headaches. A lot of times post-concussion syndrome, which was a really, really hot topic maybe 5 or 6 years ago in terms of people getting perpetuating concussion symptoms for 10 months. I had that. I had concussion symptoms for 10 months. That's a result of suboccipital tension, shortness, pulling on that nervous tissue and causing excessive headaches.
You touched on a good point too, which I think a lot of people would experience, which is upper trap trigger points. Mm-hmm. These big old muscles on top of the shoulders here that we love to get in and release and get a stick in there or a ball or something like that. And that's often one of the things that is going to show up for someone when they maybe wake up in the morning and they can't move. That upper trap is just a nightmare. I guess let's explain a little bit about why going after that as a treatment, as a primary treatment target, it's a little bit like what we talked about in the low back, right? So if we're chasing that symptom by going in and releasing that, we're kind of missing the bigger picture, right?
Yeah, I mean, that muscle is going to spasm to a varying degree. The levator scapula is going to spasm to a varying degree. And again, it's just a protective measure. It's trying to prevent your disc from getting more hurt than it already is, right? I mean, you don't want symptoms running down your arm. You don't want unrelenting radicular pain going into your fingertips. So again, same situation where, you may need to go into the levator, you may need to go into the trap to alleviate some of that tension at one point, right? To remove some of that adhesion that's just secondary to that muscle being turned on for so long. But if you go in there and you release those muscles, you blast them with enough feedback to get them to relax, and you make one wrong turn, and yeah, your cervical orthopedic surgeon is going to be very happy for the deposit that you just made into his bank account.
So we've got some low back, some hip, and some neck. And look, the key with all of this is that the way that we're looking at it is not just based on symptoms. The symptoms are important, but what we're actually doing is using that information to then put that together with functional testing to understand what has driven these symptoms to be a problem. And then that becomes what we need to fix. So this is a little bit different, I guess, isn't it? I mean, in general terms, because a lot of the time that symptom is the treatment target. And that may be important in some cases, but most of the time we're heading in a different direction to get on top of these problems and to stop that cycle and stop it perpetuating further down the track.
Yeah. And a lot of times what we run into is kind of momentum from what's currently acceptable in musculoskeletal health. So when sometimes you tell somebody something, you're like, it's not because your hips are uneven, it's not your QL, it's not your psoas, it's not your trap, it's not your levator. Like, you get actual resistance from them, right? They're like, no, it can't be. I went to this doctor, went to that doctor. I went on WebMD. I Googled it. This guy on Instagram said this. This guy on, YouTube said this. And it's like, we are fighting a battle against the momentum of a poorly set up musculoskeletal world. And it's like, you look at things that were once colloquially accepted throughout history, and you look at where they are now, and, we're going to be the ones that are on top in 50 years. We're going to be the individuals that, have fixed more people in 50 years. So it's just one of those things where even if every doctor you've ever went to told you it was your hip flexor, I'm here to tell you that every doctor you went to is wrong. Straight up. I can't be more direct about that. I'm right. Your doctor's wrong. And it doesn't, it makes me feel good about myself, but it's not because I want to feel good about myself. It's because I functionally want to improve you.
Yeah, some people don't want to hear that as well. And so, we can give them this information, but they're going to go looking for the person that they know what answer they want, right? So they're going to go and chase that. But look, the whole flavor of this podcast, the reason that we do this, it's the Centenarian Project. We're looking way down the track. We're trying to make these joints last. We're trying to get the most out of the body, and chasing symptoms and releasing trigger points in the QL or the upper trap and just letting that fly. That's not a long-term solution. So, the whole idea of this is that we're getting the most out of these joints. We're actually going after the dysfunction that caused that problem in the first place. So there you go.
Yeah. I mean, if your hip has a lifespan of 100 years, a misdiagnosis can be worse than no diagnosis at all. Does that make sense? Like, if you go to the wrong doctor and that wrong doctor treats the wrong thing, you can reduce the lifespan of your hip more so than if you just don't go to somebody, right? Like, that's as crazy as that sounds. Again, what we talked about, your L5S1 joint, if you irritate that disc and you don't go and see anybody, that disc is going to have a longer lifespan than if you go to somebody and they treat the wrong thing. So it's monumentally important to go and find those right individuals so that your joints can age healthy. You can age healthy. You can actually use them, right? Which is the other side of that Centenarian Project coin, right? Be able to use and enjoy your life, but be able to live comfortably until you're 100.
I love it. So let's sum it up. We've got top three kind of things, top three regions that we see quite commonly that come in with potentially an idea of what's causing the pain, and we're going to suggest it's something different. So
no suggestions. It is something different. So I want that assertiveness out of you, Chris.
So let's go number one. We started with the low back. We're talking about symptoms that are tightness, spasms, QL trigger points, and we're leaning towards a disc in most cases being that problem. And we're saying don't go in there and release these tight tissues just to give you your movement back. You need to get this looked at and you need to understand what's going on. Number two, we're going to the hip.
Yeah, front of the hip pain is not your hip flexor in the bottom of a squat or while you're sitting down. If anything, you're going to waste a lot of time, a lot of energy, a lot of money going to providers that are going to treat that front of the hip, or you're going to spend your kid's retirement fund trying to find the next new fancy ass fucking soft tissue tool, trying to treat that to no avail, and get an accurate diagnosis, whether it be soft tissue related or degeneration related, and get it fixed.
And then number three, we're going up to the neck. Again, muscle spasms, can't move, upper trap trigger points, rhomboids are sore. I'm sore between the shoulder blades. It's coming from where you don't think it is, and you probably don't know that you're missing that amount of function. Need to get it checked. It's not a good idea just to go in and release this stuff because it's going to keep coming back. And I can guarantee if you're listening to this and you're going, oh yeah, I get sore in those places, it's probably been coming back for a long time. So time to get on top of it properly.
Yeah, there's no tennis ball or lacrosse ball drill that's going to get that to go away. You can, I'm sure the wall at your gym or the wall at your house is very, very pleased that you've been sticking your ass in it for the last 4 years, but you're not making any difference.
All right, there we go. We got another week in the books. We're episode 13, so we're cruising ahead. Hopefully there's some good stuff there for people. If you've got any requests, any topics you'd like us to cover off, any questions, please shoot that through, and we'll be back next week.
Have a good one, guys.